Hand anatomy overview. This slide gives you an overview of the hand anatomy. On the left side of the screen, you can see the anterior aspect of the hand, and on the right side of the screen, you can see the posterior aspect of the hand. If we go to the left side first, you can view the intrinsic muscles. So here you can see the intrinsics, they originate and insert within the hand. Extrinsic muscles, they originate outside of the hand, but insert within the hand. So on the screen, you can view that the thenar eminence, these are a bundle of intrinsic muscles that originate, insert within the hand. And then over on the small finger side, this is the hypothenar eminence, and these are muscles that originate and insert within the hand as well. On the right side, you can view the extensors, and these are extrinsic extensors that are coursing down to the hand. So the white aspects that you're seeing are tendinous. So remember, muscle turns into tendon, which then turns into bone. But you also see some intrinsic muscles. So the kind of reddish tan, that is more of a muscle belly. So we're viewing some interossei that have attachments into those metacarpal bones and also into that extensor mechanism. This slide views the bones of the hand and wrist. So we can see the radius and ulna. The distal radius is such a common area for fractures from Fuchs injuries, fall on an outstretched hand. So oftentimes on an image, the OT might be looking to see how severe that fracture was at that distal radius region. Also, you can view the 8 different carpal bones. You can move distally and view the metacarpal bones that are found within the palm of the hand here, the metacarpals, and you can refer to them using numbers. So the first metacarpal would be the thumb metacarpal. Second metacarpal would be the index finger. Third metacarpal, fourth metacarpal, and fifth metacarpal. So knowing how to tie those numbers to the particular finger and bone, it will be important. As you move past those metacarpal bones, you come to a joint. These are your MCP joints. So you have flexion, extension, adduction, and abduction that occur at that MCP joint. As you move distally, you come to the proximal phalanx, okay, the proximal phalanges. And as you move beyond that, you'll then get to a joint, and this joint is your PIP joint. So at this point, you have flexion and extension at all of those PIP joints. Then we have the middle phalanx and the distal phalanx. Between the middle and the distal phalanx, you have the DIP joint, distal interphalangeal joint, that also has flexion and extension there. When referring to the phalanges, you can also refer to them as P1, P2, and P3. So this would be P1, the proximal phalanx. This would be P2, the middle phalanx. This would be P3, the distal phalanx. Note that the thumb only has proximal and distal phalanx. So you only have P1 and P2 for the thumb. Here we can also view the bones of the hand and the wrist, and we're going to zoom in and take a look at the carpal bones. Remember, you have 8 different carpal bones, and you have a distal carpal row and a proximal carpal row. So we'll start at the distal carpal row, and let's take a look at that first metacarpal bone. It articulates with the trapezium carpal bone. Okay, this is such a common area for osteoarthritis in individuals. So exquisite pain and tenderness within that trapezium bone or at that first CMC joint can often occur as we age with wear and tear, with pinching and grasping different functional items. Next to the trapezium is the trapezoid, which articulates with the second metacarpal. Then we have the capitate, which articulates with the third metacarpal. And then the hamate articulates with the 4th and the 5th metacarpal. So I like to say it hogs them, ham for hog, and it takes up 2 metacarpals instead of just the 1. You have the hook of the hamate, which with a fall can also be fractured occasionally. So that makes up the distal carpal row. As we move to the proximal carpal row, starting on the radial side of the wrist, you have your scaphoid. This is the #1 fractured carpal bone, typically due to a Fuchs injury. So if somebody falls and they're exquisitely tender in their anatomical snuff box, which is here, that is exactly where that scaphoid bone is found, and oftentimes means that there is an associated fracture there. Next to the scaphoid is the lunate. And between the scaphoid and lunate, you have the SL ligament, which is a very commonly injured ligament, again from a Fuchs injury. So if they're tender between those two bones, that could be due to a ligament injury. Next to the lunate, you have your triquetrum, and on top of the triquetrum, you have this small pisiform carpal bone. Looking at anatomy and radiographs, here you can see an image on the right side of your screen, and this is an example of a displaced fracture. So you're going to be learning down the road about non-displaced fractures where there's a crack in the bone, fracture in the bone, but there's no shifting between the pieces. And then you have a fracture of the bone where there is shifting between the pieces. So you can see things have shifted out of alignment. So this is a type of displaced fracture, and this is to the 5th metacarpal bone. And this is oftentimes referred to as a boxer's fracture because typically people with this type of fracture, it's injured from a punching force, an axial load that breaks through that neck of the 5th metacarpal. Here we can see an image of cutaneous nerves to the hand, and some of these nerves also provide motor to the hand. This is more of an anterior view of the hand, so it's looking at this aspect of the hand. And we can see that the median nerve courses down through that carpal tunnel, and it has branches to the thumb, the index, the middle, and half of the ring. The ulnar nerve, it courses down through Guillen's canal, and it's going to then progress to the small finger and half of the ring finger. On the dorsum side of the hand, which you're not seeing here, you will also have the radial nerve. This is a cross section of the hand. So if you imagine a sliced type of a view that crosses through the wrist and then looking down at it, you have a really good view of the carpal tunnel here. So you can see the floor of the carpal tunnel are the carpal bones, and then the roof of the carpal tunnel, that's going to be the flexor retinaculum, or also called the transverse carpal ligament. Within the carpal tunnel itself, you have the median nerve, the flexor pollicis longus tendon, the flexor digitorum superficialis tendons, and the flexor profundus tendons. This slide gives you an appreciation of the innervation within the hand. So the image on the left is a dorsal view. The image on the right is a volar anterior view. And so if we start on the dorsal view, we can see that radial nerve is going to innervate this kind of radial and posterior aspect of the hand. So if somebody comes in to you and reports numbness and paresthesias or tingling within that area, most likely there's a radial nerve compression or some kind of nerve injury to that particular branch. If somebody comes in and they're reporting that they're feeling numbness and tingling through the small finger, half of the ring finger, on both the back of the hand and the anterior aspect of the hand, you can see here that that is all ulnar nerve territory. And then median nerve, you can see on the anterior aspect of the hand, it picks up the thumb, the index, the middle, and half of the ring finger. Remember, the other half is ulnar. And then on the dorsum aspect, it'll be the tips of the thumb, the index, the middle, and half of that ring finger. So oftentimes it's a puzzle trying to figure out how their symptoms are matching up with which nerve that might be involved. Here we can see again on the left side of the screen a type of sensation breakdown with the radial nerve, the median nerve, and the ulnar nerve. This is a dorsal view. And then on the right side of the screen, you can see a dermatome type pattern. So dermatomes are more likely to present if a client has an injury more proximally, typically brachial plexus injuries, and typically involving nerve roots and nerve trunks. So the C6 nerve root is oftentimes tied to the entire thumb having sensory deficits. The C7 nerve root is oftentimes tied to the entire middle finger and sometimes index finger having sensory deficits. And the C8 nerve root is oftentimes tied to that entire small finger and sometimes ring finger having sensory deficits. Hand vascular supply. So the hand needs blood flow to feed the bones and the tendons and the muscles and the soft tissue. If we look, you've got two main artery supplies, the radial artery and the ulnar artery. And those feed both the superficial palmar arch and the deep palmar arches within the palm of the hand. And then off of those arches, you have the common palmar digital artery, and then that progresses down to the fingers with the proper palmar digital artery. So a good way to remember that is that the proper people are above the common people. And so I've heard students talk about that as a way to remember it and think about how both that radial artery and ulnar artery contribute to those different types of blood flow and circulation patterns within the hand. Intrinsic muscles. So remember we talked about the intrinsics, they originate and insert within the hand, and then extrinsics, they originate outside of the hand but insert within the hand. So here you can see the hypothenar intrinsics the hypothenar on the ulnar side of the hand, and then the thenar intrinsics on more of the thumb side of the hand. If we zoom in and look at the thenar eminence, these are muscles over on the thumb side of the hand, and we can view the flexor pollicis brevis. That is going to be responsible for flexing at that MCP joint of the thumb. We can see the abductor pollicis brevis. That is going to be responsible for palmar abduction. If we're going to grasp onto our coffee mug, we need palmar abduction, something that's really essential in the morning time. And also opponens pollicis. Opponens pollicis is bringing that thumb across, opposing, for example, to grasp a coin, holding onto that quarter and opposing that thumb across to the other fingers. With opponens pollicis, you can see that it's a pretty deep muscle, and it has origins and insertions listed here. And it has this ability to kind of rotate that thumb across the palm for different functional activities. So you might oppose to hold on to your earring, to put your earring in. You might oppose to hold on to change. If you lose that ability to translate that thumb across, there's no way for your index finger to make contact for pinching patterns. So essentially, you rely on that opponens pollicis to be your key muscle for all of your functional pinch patterns. The abductor pollicis brevis. You can view the origin, insertions, and actions here. But a really key action is that palmar abduction. So when we talk about abduction, we've got different types. We've got radial abduction, which brings the thumb into extension at the CMC joint. We have adduction, which tucks the thumb into the side. And then we have palmar abduction, which brings the thumb away from the palm. This is the really functional motion for grasping onto your jar of peanut butter, for example, or grasping onto your coffee mug. This is one of the most key muscles within your hand, and it is innervated by the median nerve. So this is a really good one to test if somebody has the medial nerve damage and you're wanting to know how the motor aspect is involved. The flexor pollicis brevis. You can look through the origin and insertions. The action is to flex the thumb, specifically at that MCP joint here. So typically this works along with the opponent's pollicis to do a lot of your pinching and grasping patterns. The adductor pollicis. This is going to be extremely important to adduct the thumb. So when you are going to adduct the thumb and grasp a key to open up your front door or to turn the ignition in your car, you'll want to definitely activate this muscle. And the adductor pollicis, I want you to make a note here to correct that its action is to adduct the thumb, and then also the innervation, even though it's on the thumb side of the hand, it's actually innervated by the ulnar nerve. So in this slide it says median nerve. I want you to correct that and put that it's the ulnar nerve. Now let's talk about the hypothenar eminence. With the hypothenar eminence, these are the muscles over on the ulnar aspect of the hand here. And we've got a few different muscles to talk about. We've got the flexor digiti minimi. On this slide it says brevis. Typically it's not referred as a brevis in text because there is no longus. It's just referred to flexor digiti minimi. You also have the abductor digiti minimi, which is going to abduct that small finger away from the hand. And you also have opponent's digiti minimi to try and bring that small finger over to the thumb side of the hand. The abductor digiti minimi, you can see the attachments here, and then also know that it's part of that hypothenar eminence. So it is innervated by the ulnar nerve. The flexor digiti minimi, this muscle is going to flex at the small finger, the fifth digit MCP joint, and it's also innervated by the ulnar nerve. Opponent's digiti minimi, again, this is going to draw together that thumb and small finger to grasp different functional items, innervated by the ulnar nerve. Lumbricals. Lumbricals are a really interesting muscle because they have no bony attachment. They attach purely to tendinous tissue. So they are going to originate off of the FDP, flexor digitorum profundus tendons, and they will insert into the extensor mechanism. So no bony attachments here. And they are key with MCP joint flexion and IP joint extension. So these are referred to our lumbrical grasp. So if we're going to grasp a functional item like deodorant, for example, you might be in that lumbrical grasp pattern where the MCPs are flexed and the IPs, IPs meaning PIPs and DIPs, are extended. You might also be engaging these lumbricals if you are reading a book. So here you can see that the MCP joints are flexed and the IP joints are in extension. And I'm reading a very important book here, which you should all probably have at this point, your APA manual, which you'll be using throughout the class. So this is very appropriate for this presentation. You won't use it in this class probably, but some of your other research classes. If you look at the lumbricals, you need to also know that they have dual innervation. That's another fun fact about these lumbricals. So the lumbricals 1 and 2 are median nerve innervated, and then lumbricals 3 and 4 are ulnar nerve innervated. With the palmar interossei, these are innervated by ulnar, so the ulnar nerve is going to innervate all of your interossei, And remember, you have both palmar and dorsal. So with palmar, I like to think of pad, P-A-D. So I know P for palmar, they are going to adduct the fingers, bring those fingers in. With dorsal interossei, I think of dab, D-A-B. They are going to abduct those fingers. So they're going to bring those fingers apart. So if you are, for example, washing the wall and you want some finger abduction, you're going to be recruiting some of those dorsal interossei. And both dorsal and palmar are ulnar nerve innervated. We've talked a lot about the intrinsic muscles. We've talked about the muscles within the thenar eminence, the hypothenar eminence. We've talked about the lumbricals. We've talked about the interossei. And those make up a big part of the hand's function, but we also have these muscles, they're extrinsic muscles that originate outside of the hand, and the muscle bellies are typically in the forearm, and then they turn into tendons and they cross the wrist and insert within the hand. And so they are really important for function as well. We have different layers. We've got a deep layer, intermediate layer, and superficial layer, and different muscles are within those layers. The FDP, flexor digitorum profundus, this muscle is going to flex at the DIP joint. So it's a really key muscle for functional grasping. So for example, if you go to grasp your toothbrush, you need FDP to be able to flex that last joint, that last DIP joint, to get a good composite fist. Also, you've got flexor pollicis longus. That is going to flex at the IP joint of the thumb. So, for example, if you are trying to grasp an earring, you need some IP joint flexion of the thumb. You need to be recruiting that flexor pollicis longus there. If we move to the intermediate layer, there's flexor digitorum superficialis. So this muscle is going to flex at the PIP joint of the hand. So typically FDS and FDP are working together for different functional grasping patterns. And then the superficial layer, we've got flexor carpi ulnaris, flexor carpi radialis, and palmaris longus, being your wrist flexors that are drawing that wrist down into a functional posture. Also with extrinsics, you have the extensors that are built within the posterior aspect of the hand, and you've got extensor digitorum, your extensors for the wrists, your EPL, extensor pollicis longus. So don't forget about also those extensors for the hand that are extrinsics. Finger structures. Finger structures here, we can see we've got collateral ligaments. These are stabilizing ligaments on either side of those joints, the MCP joints, the PIP joints, and the DIP joints. All these joints have collateral ligaments to essentially stabilize and hold that joint into alignment. On top of that, we have soft tissue, primarily the extensor mechanism that is going to help move those fingers in different functional postures. So we can see there's a central slip component of the extensor mechanism. Central slip is going to extend at the PIP joint. So remember, the FDS will flex at the PIP joint. The central slip will extend at the PIP joint. The FDP will flex at the DIP joint. The terminal tendon will extend at the DIP joint. You also have a variety of different pulleys. You've got A1, A2, A3, A4, A5 pulleys. And pulleys essentially are bits of soft tissue that help draw the tendon close to the bone. So we're talking tendons like FDS and FDP. And so the more that tendon is close to the joints and close to the bone, the better biomechanical advantage the individual will have to make a functional fist. Okay, here we can see there are also cruciate ligaments. These are the kind of X-shaped ligaments. We've got C1, C2, and C3 that also help support those tendons to the bone. The really key annular pulleys to think about for functional use are A2 and A4. These are critical to prevent bowstringing. So if you think about a fishing pole, the pole itself, think about that being equivalent to the finger bones. On the fishing pole, you have the loops and then the fishing line that goes through the loops. So think of the loops as being the annular pulleys, and then think of the fishing line as being the tendon that is going through the loops. The fishing line is equivalent to your FDS tendons, the FDP tendons, and it's going to give that fishing pole a better biomechanical advantage if the line is close to the fishing pole. If those loops are cut away, then the fishing line sags away from the pole and it doesn't function properly. So same kind of thing with the annular pulleys for the hand. If A2 pulley is cut or ruptured, or if A4 pulley is cut or ruptured, that tendon drifts too far away from the bone. It's put on too much slack, and the client typically cannot make a functional fist. So they're unable to grab their hairbrush. They're unable to grab their toothbrush. That can lead to lots of different complications. Here you can see on the left side of the picture intact A2, A4 pulleys, and so the client is able to make a good functional fist. And then on the right side of the picture, you can see the A2 pulley has been cut and ruptured, and so you can see that tendon is now drifting away from the bone and making it really difficult for that client to make a fist. Okay, another picture of the A2 pulley being ruptured and leading to bowstringing. With trigger finger, this is an impairment that you'll probably learn in the curriculum further down the road. But basically, you have inflammation of either FDS or the FDP tendon, and you can see in the picture in the red box, you have a swollen tendon. And when that tendon swells up, it makes it really difficult for it to travel under the pulleys. And it gets stuck, and it can lead to popping and triggering within the finger. And so oftentimes what the doctors will do in this situation is they will go in and they will cut the A1 pulley, and that will allow that swollen tendon to be able to move through into flexion and extension a lot better without getting stuck under that pulley. A1 pulley is not an essential pulley, so people do just fine after that being released, but if the doctor accidentally cut A2, that would lead to bowstringing, and that would lead to a lot of complications. Talking a bit more about the extensor hood. Extensor hood, also called the extensor mechanism, it's got a few different terms to kind of talk about all of the extensor soft tissue that covers over the MCP, the PIP, and the DIP. So it's kind of this umbrella term. And in this view, we're looking at a dorsal aerial view. We can see that over the MCP joints, we have sagittal bands on either side that really anchor that common extensor tendon or the extensor digitorum tendon central over the MCP joint. As we move down distally, we can see that you have a central slip that is going to cross the PIP joint and insert into P2, the middle phalanx. That central tendon or slip is going to extend at the PIP joint. On either side of the PIP joint, you can see in the image there are bits of soft tissue that cross on either side. They are called lateral bands. And then those lateral bands, once they cross the PIP joint, they then merge together to create a terminal tendon that crosses the DIP joint and inserts onto the distal phalanx, or P3. So remember that the terminal tendon, it is responsible for extending at the DIP joint. Here we can see a lateral view of the extensor mechanism, aka extensor hood. So over the MCP joints, that tissue that you're seeing there, those are the sagittal bands. As you progress down, you can have an appreciation of the central tendon or slip that's crossing over the PIP joint. You also see the lateral bands there, and then them merging together to attach to the distal phalanx as terminal tendon. You can see on the underside of the finger, you have the FDS and the FTP tendons there. And then you can also see that the lumbricals and interossei, these are intrinsic muscles. They have direct insertions into that extensor mechanism. So they're really the muscles that are contracting and pulling on that extensor mechanism to both flex at the MCP joints and extend at the IP joints. Okay, another good view of the lumbricals and interossei contracting together to flex at the MCPs and extend at PIP and also DIP via the extensor mechanism. Some injuries that you'll be learning about in various courses to the extensor mechanism. Mallet finger is a really big one. So if there is trauma to the tip of the finger where it's forcefully flexed, for example, from a ball or a racket or bumping into something or someone, you can actually tear off your terminal tendon. And when that happens, people present with a flexed DIP and they cannot extend it. Typically, the therapist can extend it, but if pressure is taken away, it falls into flexion. And on the image on the right, you can see that sometimes the bone is actually avulsed away. So you can have a bony mallet where the bone is avulsed, or you can have just a regular mallet where there's no fracture, but the terminal tendon has just torn away. On the image on the left side of your screen, this is the way that the OT can treat it. So OTs oftentimes will fabricate different types of orthoses to help with positioning. In this case, we want to extend that DIP and hold them there for a long period of time to make sure it heals up and they gain back that functional terminal extension. Some other deformities that are really common with the extensor mechanism, swan neck deformity. And some of you in this class may actually have this deformity if you have a lot of laxity in your fingers and in your soft tissue. With this swan neck deformity, what happens is the PIP joint falls into hyperextension and the DIP joint falls into flexion. And if you look on the picture on the left, when the PIP falls into hyperextension, those lateral bands migrate dorsally, okay? And because they migrate dorsally, they put a lot of slack through the terminal tendon. And when there's a lot of slack on that terminal tendon, you can have that DIP joint fall into flexion, okay? So this is a pattern that you're typically, as an OT, wanting to address and maybe fabricate them a type of orthosis as seen on the right to block that hyperextension. Boutonniere deformity. This is the exact opposite of a swan neck deformity. So with a boutonniere deformity, oftentimes the problem is a rupture in the central slip. So central slip we know is going to extend at the PIP joint. If central slip is not intact, then the PIP joint falls into flexion, okay? When the PIP joint falls into flexion, the lateral bands will migrate volarly or anteriorly. Okay, and when that happens, it's going to pull, like pulling reins on a horse. It's going to pull that terminal tendon very taut, and it's going to force the DIP joint to fall into hyperextension. So you have more of this type of a presentation with your clients. Some other anatomical structures within the hand to be aware of. The palmar aponeurosis. This is a a part of tissue that is a palmar fascia within your hand, and it provides support to the hand. And in some clients, you can have it become diseased and have a contracture of that part of the soft tissue. When that happens, this is known as Dupuytren's, which you will learn more about down the road in your treatment classes. But with Dupuytren's, as seen on the left side of the screen, you might have cords or nodules that form. In the picture, it might look like a tendon on that left picture and also in the middle picture, but these are not tendons. They're actually contracted palmar fascia that actually has a genetic component to it. And on the picture on the right, this is where the doctor went in and excised and removed a lot of that diseased fascia. Thinking about normal posture of the hand. So what I want all of you to do is just take a look at your normal posture of your hand right now. It's probably not all the way in extension, right? It's got a normal flexion cascade of the fingers. The thumb tends to fall in a little bit more of a palmarly abducted position. The fingers tend to fall in more of a flex posture. So whenever you're evaluating somebody, it's really important to just look at the posture of their hand. And if it's anything but this posture, then they may have a muscle imbalance, they may have a nerve injury. The arches of the hand really feed into the posture of the hand. So we rely on these arches to provide good functional contours. You have the longitudinal arch, which is an arch that travels over this way within the hand. And then you have these more proximal transverse arches and distal transverse arches that provide the contours of the hand in a different direction. If we didn't have these arches, the hand would be quite flat. And when it would come to grasping around a coffee mug, you wouldn't have the contours to really embrace and contour to the different functional items. We're going to talk a little bit about prehension here, but then you'll get it a little bit more in some of your other presentations. You rely on a lot of these intrinsics and extrinsics that we've discussed to assume all these different types of functional grasps. The first grasp that we'll talk about is a cylindrical grasp. So grasping around our Starbucks coffee mug, we're using a cylindrical grasp. Grasping around our Skippy cream peanut butter, you're using that cylindrical grasp as well. And we're recruiting some of our finger flexors, some of our intrinsics, our thumb musculature, our abductor pollicis brevis, to really allow that hand to function and grasp within these patterns. We also have a tip grasp. So this might be where the client is wanting to put their earring in and needing to use that fine motor tip grasp in order to do that. So you're essentially taking the tip of your index finger and the tip of your thumb and holding onto a functional item like an earring or like a coin. You have the hook grasp. And it says snap there also, but usually it's referred to as a hook grasp. And this is where the MCPs are in a little bit more extension, but the IPs are in flexion. So you're really recruiting the FDS and FDP as if you were going to grab your groceries or your purse or some kind of handle. You would use this hook type grasp here. You have three-jaw chuck. Three-jaw chuck can be used to hold on to a writing instrument. So if you're working on writing and you're using the thumb, the index finger, and the middle finger, that is going to be a three-jaw chuck. And because you're moving it, oftentimes it's referred to as a dynamic three-jaw chuck prehension pattern. Holding on to chapstick. To put chapstick on, you're also using three-jaw chuck. So using the pads of the thumb, index, and middle. And that's a good type of a pinch to also assess with your pinch gauge when you start to look at different types of strength with different types of pinches. A spherical grasp is a functional grasp in which the client takes a sphere type object and grasp around, for example, a loofah for bathing. A lateral grasp is a grasp such as a key, grasping a key to get in through your front door or turning the ignition in your car. So you have a flexed index finger and then that thumb that comes over to stabilize an object against for a functional purpose. And one that's not on here is a disc style grasp. And a disc style grasp might be you holding on to the top of a pasta sauce jar lid or peanut butter in this case to twist off the top to make a peanut butter and jelly sandwich or to open up your pasta sauce to make a spaghetti dinner for meal prep purposes. So as an OT, it's really important to document why your clients are having these type of prehension difficulties, for what neurological purpose, whether it's a sensory purpose or a innervation purpose for a motor level issue where certain muscles aren't engaging, and maybe documenting through range of motion difficulties or manual muscle testing strength difficulties. So essentially, it's important to kind of use these grasps and state if a client is unable to do these for certain reasons, and then show progress in your occupational therapy and towards your functional long-term goals.